Hi guys, welcome back to the Adaptive Zone podcast. My name's Matthew Boyd. I'm a physiotherapist and running coach. If you enjoy the episode, please like and subscribe. And if you're so inclined, share it with a friend. Today we're going to be talking with the endurance physio, Mike James. Mike, thank you for joining us.
Thank you. Thanks for the invite.
Before we get into it, we're going to be talking a little bit about when rehab for running injuries doesn't go very well and the reasons that might happen. Before we get into that, could you just tell us a little bit about you and your background and your professional work?
Yeah, of course. Yeah. Sadly, it's a long story. I'm getting old. But the shortest version possibly would be that I've spent 25 to 30 years predominantly based here in the UK. I've worked within the military, I've worked within elite sport, I've worked within the private sector, the public sector, and fortunately for the last 10 to 12 years, I've been able to have my own business, the Endurance Physio, which exclusively works with athletes of all endurance flavours. There's a coaching arm where we have a element of athletes that we coach. Some of those are post-rehabilitation and they stay with us for rehabilitation. I'm using the Royal S, it's me. And some are people who are just referred to us or find us organically. That's then supplemented with the rehabilitation wing and the sort of conditioning wing of that business. So it's a bit of a one-stop for all endurance athlete players. It's my passion as well as my profession. It's my background. I've been fortunate enough to compete all around the world at various levels, including a couple of years as a full-time athlete. And I've done everything from marathons to ultramarathons to Ironman to channel swims and everything in between. So I like to think that I bring an empathy and an understanding of the runner and the athlete that perhaps some don't, which is coupled then with a sort of balance of professional skills that are honed within this area over those few decades. In recent years, I've moved a lot of my business into online and online teaching, online coaching, and that probably takes up about 50% of my business these days, which breadths across athletes, coaches, therapists. I work in a sort of consultative way with a lot of therapists, working with runners who are seeing them in person, and I'm remotely sort of helping as much as I can. And then I guess the final addition in the last 3 or 4 years is that I now lecture in university as well. So hoping to pass on a wider knowledge to our physio students of the future.
Right. Okay. Well, that makes you perfectly placed for what I wanted to talk about, because I'd heard you talk about this a while back and I wanted to kind of dig into it a bit more. And it is when a runner has an injury, typically they'll go for physio and that kind of thing, or physical therapy if they're in the US, or some sort of rehabilitation, and oftentimes it'll work and they'll get better just fine, and then sometimes it doesn't, and sometimes they'll go to a different physio and the same thing will happen, and they might be 6, 12, 18 months down the line having tried multiple attempts at rehabilitation and they're not getting anywhere. Now, I know running injuries is a broad kind of topic, so feel free to kind of zero in on one if that makes more sense for you. But I just wanted to chat a little bit about that. And first off, just to get some context, like if you were to look at most running injuries, do they kind of go away on their own if you get one, or do you need someone to guide you back to full recovery?
Yeah, I think you certainly don't need someone all the time. I think you need a little bit of direction and guidance and understanding a lot of the time, and most of the time with the right advice, the right patience and the right plan, you can rehab yourself or just wait. I think when we chat about things going away of their own natural progression or regression, sometimes we underestimate what that involves. We think sometimes, and it's often what brings people back into clinics, or people who feel they're cursed with some injuries that should have resolved pretty quickly. It's the fact that the rehabilitation plan wasn't, or the advice wasn't correct. And therefore what's happened is it's the same injury that's become cyclical and repetitive or just prolonged. And they don't actually need someone to break that cycle at some point. They just need the right things to break that cycle. So there are, it would probably be too black and white to say everything would get better on its own without advice. But we can certainly prolong or accelerate perhaps some of the journeys of some of our injured runners with a little bit of the right advice.
And that sort of cyclical or never fully resolving injury, could you unpack that a little bit for me? Like, what might be an example of that happening?
Yeah, well, you alluded to it earlier with the intro about underloading. That's a really good example. If you think of something along the lines of tendon problems, whether it be Achilles, patella, whether it be something these days around hamstrings or gluteal muscles, or even I tend to class things like plantar fascia problems as tendon issue type problems. These are things that normally need a modification in your running, some sort of progressive return to that running, coupled with the right advice around how to load and rehab and strengthen those type of areas. And when people have continued or prolonged problems, and they sometimes end up in my clinic for second opinions, or as you mentioned, they've seen multiple people, they're not getting better, they come back. Very, very rarely will I ever see that someone has had completely the wrong advice. Normally, all the pieces of the puzzle are there. They're just not put in the right places or done for long enough or hard enough or progressively enough. So it's almost a case of just getting the ingredients right, but the constituent parts of that cake baked wrongly. So when things persist or persevere for longer than we'd expect, I don't think it often happens. Sometimes, of course, it happens from the wrong diagnosis. Sometimes I do, there are a population of therapists who want to make money before help people, and a patient fixed is a customer lost in some people's eyes, and we know that's the world we live in. I think there's also it's something I was going to expand on later on, but I think sometimes therapists can be too safe. We can be a little bit too kind and a little bit too safe with things, which normally comes down to a lack of confidence in that particular sport or injury ourselves. So potentially we hold people back. And of course, probably more than they'll admit, our beloved runners are not the best friends of themselves sometimes. They don't like the advice that they get given. They don't like the correct things they're told, and they'll hear something different to what we say and sometimes won't follow the things we do. So we can help with that. We should be better at making them accountable and putting systems in place that help support them through that process, particularly if we know it's going to be something that's going to be a couple of months. But I think there's probably a collection of those factors that prolong things beyond their expected response. If things are put in the right place and we modify correctly and we build up correctly, or within with the right milestones and the right time markers, and we progress them in progressive loading and strengthening plans appropriately, then most people are just unlucky if they don't resolve in the time we'd expect them to. Normally they do, but I just think we get the little bits wrong.
So it's interesting as you were talking there. It almost seems like if you had a situation, so we had a runner who had knee pain, and they tried physio for a couple of months, and it didn't get better to the level that they wanted it to. And then they waited a few months, and then they tried someone else, and the same thing happened, and they were still unable to run as much as they wanted, right? It almost sounds like there's two sides to it. There's that the runner could be doing things wrong in terms of engaging with the rehab, and the therapist could be doing some little things wrong, maybe in terms of putting things together. Like generally the gist of it'll be right, but there might be some little things. So I was wondering if we could approach it from both sides. So if we say the runner, like what might be some examples of things you've seen that runners do that kind of sabotage their ability to get over like a knee pain or an Achilles pain or whatever?
Yeah, absolutely. So I think the answer for both problems is communication. I think we just don't spend long enough learning about each other almost for the purposes of that collaboration that we should be looking for. I think from the runner's point of view, sometimes it's patience. So it's the fact that these things will take a bit longer than they might want them to, and with the best of intentions, they sometimes just cut corners a little bit. I've certainly found myself, if I feel it's that type of athlete in front of me, quite happy to tell a few white lies to them about how much they should be doing or how much I want them to, because I know they're likely not to. So You know, there's certain times where if I want them to do 4 sets of 12 and I want them to be at 70% of the maximal resistance they could, maybe I tell them I want to do 6 sets of 12 and I want them to be at 80% because naturally I assume they're going to probably cut 20% off of what I want them to do. So they probably don't commit or engage fully with the things we need them to do if we're accurate with the things we want to. As I said, sometimes we can be safe, so perhaps we underload them, and they are doing the right things, and they're just not doing enough of it often enough. And then I think certainly the other side of the patient or the runner is when they, rather than do less than we want them to do, they do more than we want them to do. And again, I still think that's a communication thing, largely driven by us, that should be better at dealing with that. So I'll see people sometimes where they've been to see someone else and they've been told, stop running. Yeah, and I'm very fortunate that the way I've managed to develop my business and my clinic now is most people for their first appointment have a 90-minute appointment. So I am well aware of the luxury I have over many therapists for being able to explore conversations deeper and wider and stuff. So when they say to me, I failed rehab or I tried that loading program, it didn't work, I really scratch away at, well, explain to me exactly what you did. How often, how much, how did it progress? What did you do? Did you really do everything you said you did? Because often that's what's been missing. But the other thing they can do then, so they tend to do less than we want them to when it comes to rehab, and they often do more than we want them to when it comes to running. So if this particular case that I had before was the guy had come to me sort of prolonged chronic-y type of tendon issue, and he had a clear sort of zone that was tolerable with his running and a zone that was not tolerable. So anything over 4 runs a week and it flared things up. Anything over 5-mile runs, it flared things up. Anything over 8-minute or under 8-minute miling flared things up. So I set these parameters for him of 2 to 3 runs a week, 4 to 5 miles, 9 minutes or ish pace, and you can be fine. You can do as much of that as you want. And he comes back and, stuck to what you said. But then you start picking away at it and you realise, well, no, actually the 1 5-miler, he got carried away. He was having fun. The sun was shining. He was with his friends or her friends. That became 8 or 9 miles. And suddenly, I got carried away and we started running a bit faster. And they just, again, it's always honest mistakes. Nobody, I think, walks out of clinic and goes, bugger that. That's rubbish. I'm not listening to you. I think if that ever happens, it's largely because the advice we've given has been so wrong. I've had runners where they can run 10 miles pain-free, but they're ultra runners and they can't run 20 miles pain-free. They've gone in to see someone on the high street type of non-specialist physio for runners, and they've gone, so you're only getting this pain when you run? Yeah, it doesn't affect you in work or daily living or no. Or just stop running for a few months then. And they've left just literally going, well, that's the worst advice I've ever been given. I remember a time when one patient, I was chatting to one patient and he went, well, I just felt like they didn't have a clue what they were doing. It was like I took my car to a garage because it was playing up when I was driving at certain speeds, and they just went, well, actually, if it only makes those noises or plays up when you're driving, stop driving. And I was like, that's a brilliant analogy, a really accurate thing. So again, I think that's probably where the patients, they get impatient and they want to get back quicker than they can. But again, I think, and I don't want it to be a witch hunt for therapists, but I largely think it's us who back them into corners to make those mistakes. There'll always be outliers. There's untreatable and uncoachable athletes out there who just won't take advice at all. You can have 50 people tell them the same advice and they're just not going to listen. But they're few and far between. Often we've just not put the things right in the right way across to them. So I think that's where I am pretty patient with runners as far as I realise that they're honest mistakes and, they don't mean to break themselves or stay broken sometimes.
So in terms of the runner's side of things, they could slightly overdose to what they were prescribed and slightly underdose. Like either way, and it can be like an honest mistake, or it can be just kind of like a lack of diligence. Do you know what I mean? Like that, not being as precise. On that, so that's where the runner can kind of set themselves up for failure a little bit. But then you touched on, like, on the therapist side of things, so there's different ways in which the prescription might not be appropriate. And you mentioned one there, which is like the amount of running, right? So could you unpack that a little bit? Some of the ways that could be wrong or not dosed correctly, or not that it could be, that it often is in your experience.
Yeah, I think, and it often is, as I say, there's sometimes a lack of confidence or a safety zone that we don't like to push people past a certain point. And that actually just becomes a frustration for the patients who just go off and do their own thing. I think what we do a lot of the time is we just fail to fully understand the person who's running rather than the running injury themselves. So, John has come to see me and he tells me that this is his identity. He's a big ultra runner. He's the chairman of his local running club. He's got all these races planned. And it means this much to him to be a runner. And he's got some moderate injury that's, an inconvenience for him, but it's not sinister. I'm not worried about his health from it, his long-term health. It's not something like a high-risk bone stress injury where the conversation would need to be different. But it's just something where for the same presentation in a different person, I might be saying, we really need to cut your running back to about 20%, or we might even need to stop for a period of time, or whatever it is. But if I can find ways to communicate and collaborate with John around almost sort of shared goals, I might want you to only do this much, but I'll accept you doing this much as long as you're doing the things I need you to do. What do you think that enough is? And if they, if I can use that conversation to get them to tell me what they think the answer is, one, they're probably going to stick to it. But two, I've got them over a barrel a little way and said, well, you've gone over what you said you were going to stick to. This wasn't me setting some arbitrary sort of throwaway guesswork number to you. Similarly, the same situation with the rehab. If I want them to be doing 4 sessions of rehab a week and they tell me I'm going to get 2 in, Mike, because of my life and my work and my family, and I just don't want to do them or whatever it is, then cool, let's meet in the middle. Let's do 2 then, and we'll see if we can add a bit more in. Is there ways, if I'm giving you an all singing, all dancing rehab plan, which would be gold standard, world class rehab plan, but you tell me it's a 40-minute commute to the gym to use the equipment in the gym and you just can't be bothered to do that, then I need to realise that progress beats perfection, and my rehab plan needs to be something you can do at home that's got enough bang for your buck that will get there, but it's convenient for you, and it's not me trying to shoe on my beliefs and my complete sort of, you're not a robot, you're not a professional athlete. And I've worked with pro athletes who they don't stick to what you ask them to do either. Mm-hmm. They're humans, they've got... You get someone who's 8 months out from the World Champs or the Olympics, they'll probably do everything you need them to. You get the same athlete 3.5 years out from the Olympics, they might not be doing what you ask them to do. So I think again, a lot of the problems, even if we share the blame, are probably more fixable on our side of the fence. I think we can be much better at going, okay, and you don't have to be, I get some people referred to me, and I get some apologetic referral almost from the therapist going, I just don't know runners, I don't understand runners, well, maybe try a bit harder to understand them. You don't have to become a specialist in it, but I always tell a funny story that I got referred this referral from a sports medicine consultant that I used to work with. Can you see this, like two lines, can you please see this pleasant chap? He's 6 weeks out from the World Championships and I really think he could benefit from your opinion. So this guy comes round, and I never once even thought of going, what World Champs? And the guy comes round and he's going to the Frisbee World Championships. and my first question was like, I didn't even know there was a Frisbee World Championships. And I'm sitting there thinking, this guy's coming expecting some, really good plan to get him to the championships. And I don't understand your sport whatsoever. So the next 40 minutes was like, look, teach me about Frisbee. Teach me about the task. Teach me about the needs. How long's the game? What position do you play? What's the demands of that position? And unfortunately, this guy had a phone filled with YouTube videos of him throwing the frisbee and competing. And then my just normal physio skills kick in of, okay, so you need this sort of range of movement and you need this sort of endurance and it's this sort of muscle pattern and these type of movements. Okay, I understand the problems now. I can help you fix those problems. And I think sometimes you come in and you go, you what? You run 100 miles in one go without stopping? Well, that's just mental. No wonder your knees are hurting. I can't really help you. And of course we can help them if we just realise, well, break that down, work out what they need and start to help in whatever capacity you can. And of course we can't fix everything in one go. So the key thing for me with all of my athletes is to really be honest and firm with the timelines and the plan as a big picture thinking, rather, look, this will probably take us 3 to 6 months. However, I'd like to think if we do all the right things, we'll be closer to the 3-month mark. We certainly will try and modify and keep you running as much as we can. I understand that, I've just had a couple of conversations this week online with people who are potential coaching clients who are carrying a couple of injuries, and we've not started coaching yet because they've got big races coming up in the next 6 weeks. So I've sort of gone, right, what can I do in the short term to help you get to that start line? I'm not going to fix you. I'm not going to be doing anything in this period of time, because to fix your problem, we probably don't need to do that race. Yeah. But I know you're going to do that race, and I want you to trust me and I want you to buy into what I'm offering you. So if I can patch you up, get you to the start line, get you to the finish line, and then we deal with it afterwards, then we're probably in a better place to get there. But if we don't do the right things, and if we're going to have to kick the can down the road, and we might be talking more like 6 months. And it just needs that honesty. It just needs that confidence that we can help you, largely help yourself, but these are the things we need to consider. And I think I always say that the best but most expensive course or training I've ever done to make me a better physio was becoming a dad. Being a dad is just about negotiating and learning to give them 2 options that I'm completely comfortable with, but allowing them to think they've picked the one that they wanted to do.
Right, okay.
And that's exactly how I feel that I try to work with my runners.
Yeah.
I try to always go, well, it can be this or this, which one do you want? But ultimately, both are options that I'm comfortable with and clinically confident with that will get you to where you want to be. But it's not my way or the highway. If you want to do it this way, we'll do it that way. And of course, you'll have some athletes who come, they have access to all the gold standard equipment, they'll give you everything you need to, and it is almost a paint by numbers exercise. But that's not the majority, and it's not everyone who comes in.
Yeah, I think that the big takeaway from that was, for me, is like communication. So like if a runner is injured, they should feel that they are part of this decision-making process for the direction of the rehab. It is not prescriptive in that sense. It is a collaborative plan that you negotiate together based on like your values and your goals and all that kind of stuff. And I think something that came up as you were talking, though, 2 things. One, timeline I want to come back to, but the other was like precision. So you were talking about this runner who you said, 3 times a week, not 4, not under 8-minute mile pace or something. You gave very specific things. And I think often, I'd say the majority of the time when I talk to runners who've been to rehab, that level of precision is nowhere to be seen. It is, if it runs too much, then stop. Try running this week, but if it hurts, stop, and then, I'll see you at your appointment. That, I don't know if that's your experience, but I hear that often.
Exactly. It's too black and white. There's not enough nuance in it, and also there has to be flex in that system as well. I'll see a lot of therapists who'll say to runners things like, on a scale of 0 to 10, 10 being the worst pain you've ever imagined, 0 being no pain, I never want you to go over 3 when you're running. And I'm like, well, I've worked with athletes who've got 60-year-old masters athletes who will tell you they wake up in 6 out of 10 pain on a good day. So how are you going to rehab them? But similarly, if I've got them doing something like really early stage run, then that might be where I want them to be. But at certain points, actually, I don't mind a little bit more. If I've asked you to run a bit further or a bit harder, or we're starting to maybe integrate some directional work or maybe some hill efforts or something, then fine. For these sessions, that pain tolerance might be 5 or 6 out of 10. And all we're really looking for it to do is respond appropriately in 24 hours and get back down to where our baseline is, and we're still good with it. But it's not just it's this or nothing. It's one or the other. It's okay, yeah, let's have context and nuance to what we're doing.
Yeah, definitely. That flexibility, that nuance, and not a black and white kind of instruction. The other thing you said that I think I hear often, or I think happens often, is there's not enough explanation of the timeline to expect. So particularly for tendons, like my little saying is think months, not weeks. Like whenever I'm talking to someone about their tendon injury, and like just what to expect. And I think often there's not enough direction or explanation of that. Like this pain, we're going to be dealing with this for the next 6 months. And if they don't know that, 6 weeks in, if they still have pain, they're going to give up. And they might have been doing all the right things, but their expectations were different from what they should have been. And that leads to kind of failed rehab, but it was actually more like failed communication. I don't know if that's something you come across, but I feel like I hear that every week.
I saw this therapist, they gave me some rehab, I did it for about 10 days, and I didn't have any improvement in my pain.
Yeah.
So I stopped. Okay, I'm not going to jump down your throat and go, well, come on, you can't have honestly thought it was going to be better in 10 days. You've trusted a professional and they haven't given you that context of, look, don't expect this to get better. Tendon loading programs. Just even setting the scene to some people, look, there's a potential with this and it's good, it's not bad, but you may get worse before you get better at it. Now, if in the running advice that we've given you, it's getting worse, you need to let me know, we need to modify it even more. But actually with this stuff, if this feels stiff and sore the day after, because we've gone really heavy with it, that's fine, keep going. They're make or break stuff for most people's rehab, to just have that understanding.
Yeah.
And I think we have two problems almost on the therapy world. Is one, I think we generally are pretty poor at understanding those timelines and healing guides anyway. So I think we probably don't know well enough what we should be saying. But then we've also got this sort of systemic problem of we hate to feel like we don't know, or we hate people to feel like you just didn't give me the answer, or you've got to be comfortable being uncomfortable sometimes. We've got, how long is this going to take, Mike? I'm not really sure. I've rehabbed some people in 3 months and I've rehabbed some it's taken 9 months. And I understand some of the things that help be quicker and some of the things that help be slower. But we're sort of going to have to roll with it a little bit, communicate regularly, keep in touch lots and lots. What I do know is if we can get this much range of movement back in this timeline, or if we can get this much strength in this much, or if the pain decreases by this much, that's a really good place to be in that first 4 to 6 weeks. And then we'll have a conversation about what's next, because we could do this or we could do this. And I'm just scribbling in my notes as well, options for moving forward. And then when it comes, and I love to sort of often, a lot of the time, if runners or people I'm got a relationship with and they get in touch and go, what do you think I should do with this, Mike? Almost my first question back sometimes is, what's your thoughts? What do you think you should do? Because runners are smart. Runners researched. Runners will find out about stuff. They've never been able to find out more than other stuff. I've got runners these days who are like, the chat GPT and the crap out of stuff, and they're finding out the right answers almost. They don't know they're the right answers, but they're right. So I'll go, well, what do you think? Well, from what I've read, Mike, or from the people I've spoken to, it's probably this, this, or this. Yeah, I agree with that. So on the premise that those 3 things could work, what do you think you'd like to try? And it's not, it's not handing over control to them, and it's not letting them do anything to get better. It's understanding that I know the road we need to stay on, but I don't mind if we go off down this little fork or turn left instead of right, because I know 5 miles down the road they'll join back in and we're heading in the right place. So timelines again, I'm more of a fan these days of I'll give you a very broad timeline, but then I'll pull it in with some sort of milestone or marker target to get us to that thing. So I'll sort of say, you know, because they want a number most of the time, don't they? They want how long will this take? My mate had this and it took 2 years for him to be better. Am I going to be stuck with this for 2 years? And like, no, I don't know your friend, don't know what rehab he had, don't know his general health or whatever. So potentially you can't correlate them at all. However, I would expect it to be between X and Y. If it doesn't resolve by Y, then we need to reassess if we're on the right track, because we're probably not. But similarly, just prepare yourself that X is probably a little bit ambitious, or before X is a little bit ambitious. So just set your scene, whether you're planning races, whether you're needing to adjust your race calendar, whether you want to discuss what we do with things around that time scale. But the biggest thing you need to leave here, rather than worrying that it's going to take 3 to 9 months, is that we can't move on to the next phase until we've done this. And that's why, and then again, that explanation of, you know, I'm giving you something. With rehab, I tried to make it as run biased as possible. It looks, smells and feels like something they understand. But if it doesn't sometimes, I'm going, look, you're probably wondering why we're doing this, because it doesn't look or feel like running, but it's because we're doing this range of movement, this flexibility, this strength, this whatever, and that will allow us to do the next thing in the next. So the target is this. So even if you find this horrible, boring, hard to do, don't want to do it, this leads to that. And I know you've already said earlier to me that that's what you really want to get back to. So and then just being smart with the check-ins. You know, I see too many people. I see the big mistake I see a lot of the time is, and I'm sort of, I do have a high percentage of one and done appointments. They're, you know, I just need guidance, Mike. I need a bit of direction. Here you go, boom, send you a couple of links, send you a couple of videos. You know where I am if you need me. But if I'm working more consistently with someone, then, you know, it's like, right, I'm going to send you a message every couple of days and check in. How you doing? Any problems? Anything I can help you with? And most of the time, everyone's like, no, it's fine. It might be a kick up the bum for some to do. Oh, God, he's checking in. I better do it. But similarly, what I see when people come into me is like, well, I got given these and then I left and I had an appointment 6 weeks later. And actually, by the time I went back, I hadn't done them for a month because I either forgot, I didn't understand, they were painful. So I just stopped. And that's why that can's getting kicked down the road so often, because we're pausing and treading water with rehab, not always trying to move forward with it.
Yeah, and you mentioned the rehab, like you sort of drew a distinction between the rehab and the running, right? As like the prescription of the running, the guidance on that, and then the rehab. And on that side of things, do you feel like we get that mostly right as physios, or do you feel like you hear a lot of tales from runners where you're like, actually that was never going to work? Like, what do you mean by rehab, and where might runners have had advice that is maybe not serving them?
Yeah, I think rehab would be any form of intervention that we give someone that's normally self-managed or self-administered. That could be for pain, for mobility, for strength, for some sort of non-running component that helps them get back to running.
Okay.
Sometimes that will cross over into run-based drills, hopping, skipping, jumping, plyometric-y type stuff that are all precursors or tolerance builders to the activity they want to do. But it's just any advice. And, you know, sometimes it could be some soft tissue work. It could be whatever it needs to be. But it's not us doing something as a treatment to someone. And I think particularly if we think of traditional rehab being exercise interventions, then we are pretty average at best as a profession at being very good at giving that stuff. We've got world-class people and we've got some really, really poor people, but probably a large chunk of the profession sit in the middle where it's okay, it's not great, it's in the ballpark, but we probably aren't giving it enough thought ourselves. We paint by numbers a lot of the time. Okay, so what did I give everyone 3 sets of 10. And 3 sets of 10 might be perfect for some people, but they might be way too much or way too little for others. And then like the next progression will almost always be the same progression to everybody. And it's just, again, it'll land right for a lot based on pure just percentages. but for some it could be way off, up or down. So I think we need to be better, and also we need to be better at breaking it down to people. What does that actually mean? When you say 3 sets of 10, what do you mean? And I'm very, very sort of diligent with my rehab of the sets and the reps and the resistance levels I have. There's a big conversation around, well, what speed of movement am I getting you doing that? How long does one repetition take? What are some of the coaching cues and some of the tips that I want you to think about when you're doing that? Because I've seen people over the years where, and certainly I was to blame years ago when I was younger and perhaps a little bit less thoughtful in the stuff I get. People are genuinely doing what you've asked them to do. It's what you've asked them to do is wrong. You know, they're doing it too fast. They're not got enough control in it. They're not executing the movement in the way. And I know there's been that big shift, obviously, in the healthcare world, that specificity in some things is less important, and something's better than nothing, and it'll probably work. And yeah, I get that. But certainly with certain conditions and certain rehab plans, a little bit of specificity is very important. So I think it's just the understanding, the detail, the accountability. You know, I'm a big fan in, like, I can't stand printed exercise sheets. They're just too one-dimensional, and they're often forgotten or lost or whatever. So, you know, my athletes will get, if it's online, they'll get a recording of what we're doing. If they're in clinic, I'll grab their phones and I'll get them to film me demonstrating the exercise, and I'm giving them the coaching cues, and I'm giving them some tips, and I'm giving them the sets and reps that I want them to do, or vice versa. They're doing it and I'm explaining it. If there's family members or other people around, like, look, come in, look what I want them to do. It's your choice now when you're home, or your option to persevere and push them with these things. So I think we can just be better and more in depth and detailed with simple stuff. We don't need to overcomplicate it. We don't want to be giving them really complex scientific plans that are just losers from the start. But we can make the complex very simple, but in our brains know that the rehab's complicated in its construction almost.
Sounds like a warning flag for runners who aren't getting anywhere might be if their rehab program, if their exercise program feels a little bit like it was kind of handed to them. Do you know what I mean? Like the way you describe that, like there's videos, there's cues, there's do this, not that, there's do this amount of reps, not that many, do this fast, not this fast. Like there was a lot of specifics to how to do the exercises. And if it feels like you didn't have any specifics, that it's not necessarily that it's not the right plan, but it might be a bit of a warning flag that there may not have been much thought put into the exercises you were given. Because I know for me, that drives me nuts. Is like, okay, they have knee pain, glute bridges, foam roll the IT band, never mind about the calf. Apparently that has nothing to do with running. You know, it's just this, like, you hear the same exercise prescription hundreds of thousands of times in a career, and you're like, that's not very specific. For some runners that's really, really easy, and for some that's really hard and they can barely do it. And there's everything in between, you know? You know,
I've worked in clinics as a therapist where the sort of MO and the system of the clinic was that there's a folder or a filing cabinet, and it's like, if you've got this sheet just gets pulled out and handed to the same person. Ugh. One size fits all, cookie cutter approach. We're lazy with what we've got on the sheet. We're lazy. We explain it to the people. We probably underestimate the impact that laziness has on the, well, if you're not interested in me, I'm not going to be interested in your plan. And there's maybe 8 exercises, and we're trying to get them to do all of them when actually 2 or 3 would be enough. We know that we always blame the patient. It's always their fault. They failed rehab. Gave them all the stuff, but they didn't comply. And then you sit and you go, like, there's some seminal pieces of work out there that rehab plans, home exercise rehab plans that have 1 to 3 exercises have twice the adherence of ones that have 6 exercises or more. So don't feel that, well, particularly in the private sector, well, they're paying me and I feel I need to give them lots. And, less is much, much more a lot of the time. And if you've got a runner who's leaving going, I've got 1 exercise and he needs me to do it every day, that's probably getting done. That's probably getting done. But if they've got 8 exercises and they even 20-minute drive home, they have a tea, have a coffee, they sit down, they do some work, they get back, they look at their exercise sheet within an hour. they're probably going, I'm not quite sure what 2 or 3 of those were, because again, when I'm talking at expos or conferences to therapists only, and we're on about the clinical encounter, number one thing most go is, I wish I had more time. Well, you wish you had more time because you're trying to do so much in it. So yeah, I can never get a chance to go through my 8 exercises. And well, give them 2 then and go through the 2. Use the time you've got better, and then you're going to have a better interaction and a better bang for your buck. And that's hard. It's hard when someone's paying you money, or in the NHS system over here with the public sector, there's normally been a prolonged wait to get in to see you. So the same pressure, either financially or time-wise, where you feel I have to put on a show and do lots for this patient because you think that's what they need or want, but actually it's not. It's what you think you need to do to justify your time and their weight or their money. But actually what they want is just some really good, solid, simple advice that they can just go away and act on.
Yeah. I think if I could sum up for like the runners to take away is like, you should feel like you're communicating. You should feel like involved in the planning process. You should feel like the prescription of exercises is specific for you. And you should feel like the running guidelines have enough flexibility that you can, like, it's not written in stone, but it is that you know what you're supposed to do.
Yeah,
and I think if you have all of those things, and you should understand how long this is going to take as well. I think is the other thing you mentioned.
If you're having a conversation with a friend or someone from the running club, and the words fall out of your mouth, well, I'm working with my physio, you're probably in the right place. You're probably getting things done right, because it's this teamwork and this collaboration stuff. And if it's like, well, my physio's got me doing this or told me to do that or stopped me doing that. I'm very fortunate now that the reputation I have in the runners that I see locally, I'm sort of known as like, Mike will try to keep you running.
Yeah, me too.
So there's not a fear.
Very proud of that.
Yeah, there's not a fear of, and you see it on Facebook groups all day long, people asking for advice, and someone will just go, why are you asking for advice here instead of just going to see a professional? And a lot of the time someone will just go, because everyone I've ever seen has told me to stop running. They don't understand that I really want to keep running. So it's like, right, cool. Let me just start from the outset. I'm going to try my hardest to keep you running, but I need to understand what running is, what it means to you, what you want to do, what you've got planned. But then similarly, the double bonus of that is that on the rare occasion someone's injury needs them to stop running, they also go, well, if Mike's told me to stop running, I probably need to stop running, because he doesn't tell people to stop running if he doesn't have to. So I think, we just need to be better, but the signs need to be noticed from the patients, because I think a lot of therapists are so absorbed in their full diaries and their workload and doing what they think is the right thing, probably never take the time to reflect on our shortcomings, a lot of us.
Yeah.
So it should definitely be the runner, who even ask the question. So do you want to know about the runs I do? Do you want to know what my training history is? Do you want to know what my thoughts are on this? Yeah. I love it when someone says to me, I always ask my peer, have you done any doctor Googling? And I love it when they say yes. Okay, cool. What have you found? What do you think? What do you think it is? Why do you think it's that? And when they just go, no, I didn't know. Okay, well, and then similarly, you go like, this is a big flag after the session for me. I'll get someone coming in and they've seen someone who ordered an MRI or an X-ray, and they've had some diagnosis and they've had this package of treatment for a period of time. And they'll go, yeah, I was told I've got X or Y condition. Okay, did anyone explain that to you? No. Like, so they're treating you for something. They've given you all these fancy anatomical Latin names, and some of them are really fear-filling because they sound awful and they're not. Or they've had an image and nobody's really broken down what the complex technical words mean on the image. And they're left crippled with this fear that something bad's going on. And you're like, right, so you don't even know what, like, and it's simple, I've been told I've got trochanteric bursitis. Okay, cool. Do you understand what? No, but it sounds really bad. Okay, well, look, you've just got this little fluid-filled sac that acts as a shock absorber, helps with a bit of friction, and sometimes it can get irritated and annoyed and painful, and that's what you've got. Oh, that's it. And you've just diffused it all down. Okay, so it's a simple thing to treat, but it does take a bit of time.
Yeah.
And our plan will be this. we've got an emergency plan. If it doesn't work and respond in this time, there's other things we can do, but I don't really want to discuss them now because we don't need to. Yeah. They're only last minute options type of thing. And they, oh, do you mean things like steroid injections? Yes, exactly what I mean. Oh, cool. I wondered because someone had mentioned that. And suddenly it's a two-way conversation and it's a collaboration around stuff. And again, you'll have sometimes, I worked with someone with a bit of arthritic knee pain who was trying to run a marathon for charity. And the conversation of steroid injection for pain relief came up. And here was a guy who already had gone privately to book one in. This thing was happening in a couple of weeks. So, okay, cool. If it's there and it's in, let's use it and we'll work around it and that's fine. But if you didn't have that booked in, I'm not saying let's go get that. Let's have a conversation about whether it's worth it. What is the bang worth the buck there, sort of thing. So yeah, just being bespoke, being individual, having an approach with the patient, but it's a system you use, but the system means individuality.
Yeah.
Should be a big warning sign for runners when they see therapists that I've got a good one or a bad one here. And again, not a bad one, but perhaps just a lazy one might be a better way. Yeah, a lazy one who might just not be running specialized. And I'd like to think that I could use that approach to treat any type of thing that comes into clinic. But at the same time, I'll hold my hands up and know that certain things I am absolutely the wrong person to see. It's not my specialty. It's not my bag. So, again, for runners going in, if you've got a therapist who's not prepared to go, I don't really know how to work with people like this, but I know someone who does and I'm going to pass you on, then, don't be scared to ask the question. Do you know anyone who's able to work closely with me who might understand these type of injuries a bit better?
Yeah, I think that's the big theme here is collaborative, communicative approach. And I'm going to have to stop there, unfortunately, but I know for other runners to connect with you, I think on Instagram, if we have you at the Endurance Physio, right? So I can put a link to that in the description.
The Endurance Physio with underscore in between each word.
Okay, cool.
At the Endurance PT over on Twitter or X or whatever it's called these days. But most places you'll just find me as the Endurance Physio somewhere or other.
And Mike puts out awesome content, which is how I found him. So thank you so much for joining us, Mike. And I really appreciate it, mate.
Thank you. My pleasure.